Thanks for downloading and welcome to Take Orally, the podcast from Dream Queen's Medical Centre, Nottingham. In this episode we'll be discussing paediatric sepsis. As ever, all information is correct at the time of recording. Any and all guidelines mentioned are correct for Nottingham University Hospital's NHS Trust. Other trust guidelines may vary. All views and opinions are the speaker's own. Hello, welcome back to Take Orally, and in this episode we'll be discussing paediatric sepsis. So we have Dr. Rachel Trix with us. Hello, Rachel.
Hi.
You're ST7 in paediatric emergency medicine.
Yes, that's right.
Making your pod debut. Welcome.
I am today.
So we're going to discuss, I think, a subject that sounds scary and I think can terrify clinicians, both new and old, to paediatrics, paediatric sepsis. But we're going to start off with some definitions and then we're going to go through a very systematic approach. Is that right? Okay,
yeah, that's about it today. Obviously sepsis is the same in adults or children, so there has to be presence of an infection, and then still in children we still sort of discuss about the SIRS criteria, so infection plus either abnormal temperature, abnormal heart rate, raised respiratory rate, and obviously an abnormal white cell count, although that's difficult to tell when your child's first presenting in A&E as they don't have it written on their foreheads. We talk about severe sepsis being sepsis in the presence of cardiovascular dysfunction, acute respiratory distress, or dysfunction of more than two organ systems. And then with that we also have septic shock, so that's sepsis with cardiovascular dysfunction, which persists despite having 40 mL per kilo of fluid in the first hour. And then refractory septic shock being requiring more than 60 mL per kilo of fluid, and then they go on to sort of describe catecholamine resistant shock. So that's shock which is resistant to early inotrope use. When the child presents to us, we also have to be aware that there can be two forms of shock, although the more common one, particularly in the ED, is cold shock. So these are your children who have the increased systemic vascular resistance, so they've got reduced cardiac output, they look cold peripherally, they've got delayed capillary refill, reduced pulses, often mottled and dry. But some children will present in warm shock as well, although these tend to be more in hospital. So they have decreased systemic vascular resistance, elevated cardiac output, and often a flash capillary refill, so they look quite red, flushed, and hot. But these tend to be more in hospital patients.
So the cold shock, is that your pale floppy child?
Your pale floppy child.
The crew are running in with holding. Yeah.
You undress them and go, oh no, they're purple. This doesn't look good. Yeah. Okay. So that's more what we're sort of going to be discussing today.
Absolutely. Okay. So you've got an unwell child who's coming in and you're thinking of paediatric sepsis. Is there anything in the history that you're going to want to know? I mean, it's a time-critical presentation, so you're being brought in, the parents are there. What are you going to want to know as quickly as possible?
So how long they've been unwell. So the easy things to look out for are what is their activity level like? Are they sick? Are they running around? Are they completely lethargic and floppy? Are these children eating and drinking? Are they having wet nappies? Because obviously that gives you a really good idea of perfusion in a child. So a child who's not had a wet nappy for 10, 12 hours is probably quite sick. And from then you can go on to assess them and see how they're going. Another key important factor is rash. So we all know that non-blanching rashes are pretty scary and can be signs of meningococcal sepsis and other forms of sepsis. So we need to make sure that if the parent says, ask for that, and if they've says, well, have a look at it and check what their rash is like.
Okay. And so you've still got that quick information on the go, and we're going to start to get some observations on the patient as well. Yeah. So what sort of red flags are going through your head then?
So the main red flags for assessing a child with sepsis are a child with an elevated heart rate or elevated respiratory rate, a child with a low blood pressure, any child who looks pale, mottled, blue, obviously, and the non-blanching rash. And the one thing I would say is undress these kids as far as you can possibly. I've found non-blanching rashes is the first sign of a kid with severe sepsis under their socks. So really don't forget to strip them off completely, because you may well miss the very early signs of something. Looking at their alert and activity, so are they sitting up in bed, are they interacting with you, are they smiling, are they actually wanting to get up and play, because obviously that's a really reassuring sign, but your child is floppy in bed, that's a definite red flag. And then you can go on to do further assessments such as blood pressure and blood tests if you need to, and they will help you.
I suppose a vaccination history as well is useful.
Vaccination history is very useful, although at the end of the day, children still get sepsis, and children with full immunisation schedules often do get group A sepsis, and even our vaccinations only cover certain strands.
So those are our absolute red flags, and good advice as well about making sure that you strip the patient down properly. What about some things that are concerning but not so much a red flag, where you're going to be wanting to get some quick senior reviews, but probably not the red flags yet?
So I mentioned heart rate and respiratory rate, and also with that you've got to consider oxygen requirement as being red flags, and technically these are our red flags, but for those of us who work in paediatrics frequently, you'll know that a lot of our children come in with high heart rates because they're anxious because of the situation. They may be hot, and we know that just having a temperature for whatever reason will put up their heart rate and respiratory rate. Or they may be wheezy, struggling to breathe, and that will also put up their respiratory rate and potentially give them a need for oxygen. And yet at the same time we can sit there and we can say, actually, this child isn't septic. So certainly, although they are listed as red flags, things like oxygen requirement, respiratory rate, heart rate, it's worth looking at the child, assessing them in their clinical picture, talking with mum and dad, and any concerns about these, then just ask a senior for advice. And most people, if you've got senior registrars, senior consultants, will be happy to sort of say, yeah, no, actually I'm happy that child's only wheezy, or that they don't need early intervention. But it also backs you up then, if they do need intervention, that you've got someone there looking at the child soon.
Absolutely. So if you've got a child who has red flags, you're obviously concerned then that they are a septic child. What are you going to be doing for that child in A&E?
So these children need early intervention. So you've picked up on the red flags. The first thing that you need to get is access and a bit more information about their current status. So a blood gas is really useful for that. We talk about getting early access and sort of only having 1 or 2 attempts at IV access, because they're often quite shut down and it's quite difficult. It's hard enough to cannulate children at the best of times, let alone when their veins are collapsing and they've got a very low circulating blood pressure. So we say have 2 attempts, but really think about early IO access as an option. And then to try and get as many investigations as possible in that early time. So getting good volumes of blood in their blood cultures, because we need early identification of the pathogen. And if we don't get it, then that makes it really difficult, because how long are you going to treat this child for if you don't know? A negative blood culture doesn't necessarily mean that they would never have an infection.
Absolutely not, yeah.
Other things to consider early, and we sort of, I know you've sort of previously discussed the collapsed neonate, but thinking about things like LPs and urine samples, and getting those really early as well can help with the length of antibiotics. I know that there's been some recent studies published in the archives of disease in childhood only in December, talking about LP use in meningitis, and showing that actually those children who had their antibiotics pre-LP often ended up staying in hospital a lot longer, because they didn't have a pathogen to say how long the antibiotic course needed to be given. So it's certainly something that's worth thinking about if you've got the skill and the time to do that, and you're happy that your child is stable enough for you to do an LP. The other thing is urines, and again, we far too often set parents up with a pot and say, just catch an urine when you can, but if the child is shut down, they're not going to be producing much urine. and by the time you've given those antibiotics and they pass that urine, often it could be sterile anyway, and that could have been your source. So thinking about suprapubic aspirates, if you're happy to do that, or even just catheter insertions, you get an early urine, and then you can use that to monitor their fluid output anyway. So all things to think about early on. Getting that blood gas is probably really critical. It gives you a really good idea of where the child is at.
So it's the lactate
Of the lactate is the primary thing that we want to know on it, because that really guides our fluid management over the next hour or so and how fast we have to give those fluids. The cut-off point, as probably is for adults, although I haven't done adults in a long time, is 4. So anyone with a lactate over 4 definitely needs fluids. 2 to 4, you can start to think about it. And under 2, if they're unstable, I would still be giving fluids. But certainly if it's over 4, you probably want to be talking to your PICU and intensive care teams ASAP so that they can be aware, at least, if not coming down to see you straight away.
Very unwell child. So gas also gives you glucose, doesn't it, as well, which is useful?
Yeah, so glucose is obviously variable. Sometimes it can be high because they're stressed, but more often than not, these children haven't been eating. They've got quite low reserves, so it's also something to be aware of and treat as you need straight away, because the complications of hypoglycemia can completely mess up your treatment as well.
And so and in adults in particular, we're going against it with antimicrobial stewardship, but there is this idea of let's TAS for everybody, Tazocin. Is it much the same in paediatrics, or should you try and be more specific?
We're not using Tazocin, we're tending to use ceftriaxone as our first line antibiotic if the child is quite young. So as the neonate, then we need to think about the other causes, possible pathogens which are introduced at birth. So we include amoxicillin and gentamicin in those age groups. There's also more talk now to include at least a stat dose of gentamicin in our older age groups if we think they're shocked, just to give better cover. And generally ceftriaxone is our mainstay. Obviously if they're severely immunosuppressed, we know that they're on chemotherapy or whatever reason, then we can use more targeted antibiotics such as Tazocin, but we don't tend to use those as the first line.
At least some patients that don't get TAS. Brilliant. Okay, so that's our approach that we're taking with our patient, and as you've said, you're looking at that response that the patient's going to have as to where they're going to end up. Are we going to need Picu to come down and to review our patient as well? Just to sort of reiterate the PICU thing, obviously I think people, especially starting and paediatrics, I don't want to bother the seniors, I'm a bit scared, and we can sometimes be a bit worried about crying wolf or whatever, but obviously this is sepsis. If we're concerned, we need to be concerned. So what sort of things do we need to think about to go, this patient's going to need to go up to Picu? So
obviously the first thing is, if you've got a child who you think is septic, is getting the most senior person in your department to see this child straight away. So any child who is scoring a red flag for sepsis should be reviewed by a registrar within half an hour and a consultant within 60 minutes. And while you're getting all this, starting all the treatment as well. Early PICU involvement is really important, because we don't do a lot of management of the sort of intubation central lines, things like this, down in the department, and actually we do need their support for this, depending on who you've got available in terms of anaesthetists and extra support. They may or may not be happy to support you with this. If you're in a DGH, you may find yourself in a very different situation, and actually speaking to the PICUs early, speaking to your local transport service can at least make them aware, so that they've got you on the radar. So if they need to come and pick the child up, give you extra support, then they know. So I would always say, even if you just want some reassurance that you're doing the right thing, give PICU a call if you've got a child who's looking pretty sick and needing a lot of fluids.
It's not mess about. So shall we reiterate those things about the fluids as well? What was the cut-off you were talking about for being fluid refractory?
So our child who's got a lactate of more than 4 definitely needs at least 10 to 20 mils per kilo straight off, and if you get a little bit of response, then you definitely consider repeating it straight away. But once you've got 40 mils per kilo, these kids really need to be on inotropes, and again, that's why you need your PICU there. I know certainly in many departments, the A&E paediatric nurses, as great as they are, don't have much experience with managing inotropes. No. And actually, even if it's not a doctor you want there straight away, because you can manage that bit, you might want a PICU nurse, someone to come down, help draw up, make up the drugs whilst everyone is getting into position. If it got a lactate of 2 to 4, certainly start giving them fluids, again, 10 to 20 mils per kilo, then reassess and check another blood gas after their bolus, see how they're doing. These children may or may not end up on PICU, but still they need early fluids, as any child does. And for those with a lactate below 2, hopefully it's just their tachycardia is possibly down to something else, and really it's a matter of looking at them in the entire clinical context and speaking with your senior again.
Yeah, absolutely. Well, it's difficult, isn't it? You know, as you said, there's a psychological aspect. They're a little kid, they're scared. Have they been given, something that's made them more tachycardic, anything like that, and I think it's important to think about it. Brilliant. And you mentioned inotropes. That's really, for anybody who isn't aware listening, that's your vasopressors. You're trying to help out by increasing their vascular resistance to increase their blood pressure, essentially, aren't we? Yeah. They're not doing it themselves. No, not anymore.
I think one of the other things is there's quite a lot of debate about how much fluid we should be giving.
Yeah. And as we had in the Paediatric DKA podcast, with Colin the other year.
So should it be 10 or 20 mils per kilo? There's been previous studies which were done in low resource settings, so that was the FEAST study a few years ago, which showed that those kids who were getting big boluses actually had higher mortalities than those kids who weren't getting boluses. So that's raised some questions. Obviously it's a completely different setting, we've got a different patient group. Malnutrition is a big problem in that patient group. But it is something that they're starting to look at over here, and there's been sort of feasibility studies done for the FISH study, if anyone may have heard of that, but they're starting to look at whether we can start to address how much fluid we're giving.
Don't want to kill with kindness.
Not really, no.
And so shall we just have a bit of a chat about special circumstances then?
Yeah, so there's a certain group of patients who may turn up in the department who may look okay but are at higher risk of getting sepsis. So these are children who are immunosuppressed for whatever reason, and some of them have a nice big label on them saying, I have this disease, it makes me immunosuppressed. But there's other groups of patients who we see quite frequently, so our children who have Down syndrome, trisomy 21, that automatically puts them at risk of immunosuppression, and you've probably heard in the news there's been a few unfortunate deaths of children with Down syndrome.
Absolutely.
In other centres, but also locally as well, because they just don't have the reserves to fight the infection. And there's been moves recently to sort of improve that recognition and improve people's knowledge of that. So one of the new policies that we're putting in place here in Nottingham is that any child who presents unwell with Down syndrome, who has Down syndrome,
who presents unwell,
then they really do need an early senior review. Even if you think it's just a cold or a virus, for whatever reason, they need to be seen by either someone in the emergency department who is a paediatrician. So there's a few of the consultants who are paediatricians by background, or have done a lot of paediatric emergency medicine in their time. Or one of the more senior registrars who is also a paediatrician. So someone who's doing paediatric emergency medicine, rather than just the ST4 A&E registrars, who are great as they are, but the new policy,
an extra level.
The new policy is that they should be reviewed by someone. If that personnel isn't available, then they should be being admitted to paediatrics for that review. And that's going to be a blanket policy across the trust. So,
is this because they deteriorate very quickly?
Because they deteriorate very quickly, and they may show signs and hide signs that are more clear in other people.
So again, so I suppose that's not so much a red flag, but again, something to be concerned about if you hear that history, or if you hear from the mum or dad going, yeah, the last time they were like this, they then ended up, we were sent home, and then the next day we were in really poorly. And
and a lot of that is not just the child at the time, but it's all what the parents are feeling as well. So even if you've got a child in front of you who looks really well, if they have a history, they've lost previous siblings due to sepsis, or this child has had previous sepsis in the past, you've got to remember they're going to be really anxious. And so sometimes actually not dismissing their fears, and just, even if you're not worried, bringing them in, speaking to your seniors, getting someone else to come and have a look at them, just to reassure the parents, because they're obviously really anxious and worried.
Of course, absolutely. So you, just to, as we start to wrap up, you wanted to talk about a Delphi study which was done locally, about reassuring and not so reassuring features. Yeah, so
there was a Delphi study actually run by 2 of the ED clinicians in Sheffield, but they managed to get 195 clinicians worldwide, mainly from the US and UK, and I actually put it to them, like, what are the reassuring findings? How do you make that decision when you're a senior decision maker that these children now are actually well enough to go home?
We should just mention how a Delphi study is done. So this is where you're trying to get a bit of a consensus amongst experts, and so you send off, a question, you get their ideas, you come up with a consensus out of it, you send that out, and you see, oh yes, I agree with this, no I don't, and eventually you're trying to, through the wisdom of these experts, come up with this is our agreement. So this is what they did worldwide.
So in their process, they sort of came up with 13 statements that they put out worldwide, sort of looking at all the common things that they might think about. So it goes from activity levels, child eating, drinking, playing, talking, are they miserable, consolable, are they using a phone? That's often coming up quite frequently now. Or are they quite interested in watching YouTube on mum and dad's phone? And also, finally, is fear of the clinician, which is always a good one. But unfortunately, I think most children are scared of us.
I was terrified when I was a kid. Absolutely terrified. The irony now, but yeah, absolutely terrified when I was a kid.
I love going to the doctor. I spent my life in A&E.
Oh no, I hated it. Absolutely hated it. Never mind. So I had glandular fever. I was absolutely horrible.
Wow.
Blood test. I was dreadful.
You were poorly. I just broke my arm all the time. So.
Oh, there you go. So what did the study find out were reassuring features?
So their main reassuring features were. Are these children active and energetic? So your child who's running around the playroom, just wanting to play all the time, they were quite happy that sort of 98% found that very or moderately reassuring of their cohorts. So if you have got a child and their heart rate's high because they're running around, then I wouldn't worry about it too much. They were also quite reassured, certainly by children. So a child who's eating, they sort of were hitting 67-70% reassured. People found that very or moderately reassuring. Drinking was less so, so to be aware of that, and obviously appetite levels do increase with how well you're feeling. Again, smiling, laughing, interaction between the child and you, particularly in your young non-mobile children. If they're sitting at you smiling, making bubbles, then they're generally very well. And they've put playing as being over 90%, and smiling and laughing being over 90%, sort of very or moderately reassuring. There were some findings which they felt there was more of a consensus that they weren't reassuring, and those in particular were how consolable the child was in their mum's arms. So we talk a lot about the irritable child, and you sort of say, oh well, the irritable child is a child who can't be consoled, but I think some children will feel much happier in mum's arms, but that doesn't mean that they're not sick. And finally, again, fear of clinicians, apparently that's not a very reassuring sign at all. So yes.
As in the more scared they are of the clinician, the more poorly they are.
Yeah.
Wow, okay.
Well, potentially. I think it's just not a very reassuring sign that they're well or poorly. So
fair enough. There you go. God, I'd be admitted all the time when I was a kid. Never mind. Okay, excellent. Right, so I think that's a very sort of practical approach to the child with sepsis. As you already mentioned, we have done an episode already on the collapsed neonate. We've got 3 episodes with Phil and Colin on the Wheezy Child trilogy, so there's that as well to have a listen to. I know we're going to do some on
Fever,
non-blanching rash
yep.
and the child with fever as well, so I haven't put you off already.
No.
So then I suppose just to finally finish, if we are discharging our child, and obviously like you said, parents very worried, they hear the word sepsis, it's all over the media, and so they're obviously very scared, and they may obviously have had first-hand experience of it as well. Safety netting is very, very important. It's very important here in A&E. We're under increasing pressure to make sure that we are providing people with the correct information.
Yep.
So what sort of safety netting do we need to put in place when we go, we don't think your child is septic, but what do we need to put in?
Safety netting is really hard because you're saying, I don't think your child is unwell, but your child might get unwell. And then parents are thinking, are you actually doing your job here? Or,
this is it. Yeah,
so it's just making a really clear set of instructions. I think a lot of it is saying, at this moment, your child isn't unwell. If they came into hospital, there is nothing that we would be doing other than observing your child, which is what you can do at home. And parents are really good at looking after their children. They keep a close eye on them. So making sure, if you're going to be safety netting and discharging the child, making sure that actually you're sending the child home with parents who have an ability to get back into hospital quite easily. So if the child does deteriorate, make sure that they're not 60 miles away out in rural Lincolnshire if we were here. I've worked in some other very rural settings, and actually making sure that they can get back to hospital. And then giving them a list of sort of signs and symptoms to look out for. So particularly activity levels, we've said that's quite a key symptom. So if they're lethargic, they're not waking up properly, then that's definitely when we want to see them back. Non-blanching rashes or mottled, again, definitely want to see them back. It's just dropped out of my head. Reduced urine output, so they're not drinking, they're not interested in their feeds. Then again, want to see them back. Vomiting, diarrhea, anything really which they're not happy with, which is a change in the child's from where they are now, and make them feel really comfortable to come back, because some people sort of feel, oh, I've been to see the doctor once, I don't want to go back again now, they've said everything was okay, we'll just sit it out. But no, really make sure that they feel comfortable, that they're worried, then they can happily come back and see us again.
Oh, that's brilliant.
There will be a new leaflet as well here in Nottingham, and I'm sure if you're working elsewhere, they may already have one, so use that, because then it gives them something written to take away.
If in doubt in practice, look at the leaflet.
Basically.
I was NHS websites, there's always something you can print off and give them, and if you're in an exam, there's always a leaflet you can mime.
Yes.
And if you're in an OSCE station, give a leaflet. Just even if it's the most ridiculous thing ever, that was the best advice I ever heard for OSCEs. Just here's a leaflet. There we go. Promise. Thank you so much, Rachel.
Thank you.
That was the Take Orally Paediatric Sepsis podcast. You can find the blog entry for this podcast at takeorally.com. Remember, you can find Take Orally on both SoundCloud, Apple's podcasts, Spotify and Instagram. You can follow us on both Twitter and Facebook. For more information about research and education opportunities in emergency medicine, acute medicine and major trauma, remember to check out NUH Dream on both Facebook and Twitter.